I'm Rick Howell. I'm one of the local upper extremity, hand and upper extremity surgeons, and my practice now, just because I've been out long enough, is focused down to hand and wrist. And I'm always kind of humbled, especially in a room that's this crowded, one, that so many people have hand problems that maybe are sitting there wondering if there's anything they can do about them, and two, that they're willing to come in and listen to me talk about them. When I was younger, it used to be sympathy I gave my patients, but even over the last 8 weeks, I've started having some terrible thumb pain on my right, so now it's empathy, right? Right. So I have my slides. I've got it all in my head for decades now, but I cue off the slides, so if I get ahead of myself, it helps to keep me get back on track here. So we're going to be talking about pain along the thumb axis, and that thumb carries down to the radial wrist because there's a lot of structures that kind of run across the radial side of the wrist, which is the thumb side of the wrist, out into the thumb. And many of them can be source of similar pains and problems, but they're very specific areas of pathology. The first question people ask themselves, well, probably the first question they ask is, where do I hurt? Because something starts affecting the way they do things, and they kind of look and try to figure it out. And then they want to figure out, why do I hurt? The hands, obviously, we're using the hands for everything that we do. And we use them for protection. We're going to fall, we're going to do something, and something's going to hit us in the head. We put our hands up. So there's a lot of things that can injure the hands just on a day-to-day basis. But even your basic activities, the pinching, the pushing, the pulling, lifting and carrying, gripping and squeezing, even activities that are as minor as writing, sometimes can exacerbate pains that we have that we don't know we have. Many people have heard over the years about repetition and overuse, and that was probably one of the worst things we as hand surgeons did 40 years ago. All this information got onto the workplace, and now everybody's locked on to this repetitious disease. And actually, most of that has gone out the window now. If you look on the orthopedic site, they still have it there. But if you look at the hand surgeons, it's mostly life. It's usually a culmination of a bunch of different things that are kind of coming together at the same time, like the planets aligning, and all of a sudden, it pushes you over the edge from being in a state of not having symptoms to being in a state where you have symptoms. So I have life up at the top because, overuse, which I would prefer almost to say misuse. In other words, you do something wrong, you use your hand as a hammer or something. And those are the things that truly can be causative. But overuse isn't necessarily considered a cause. I have people that have done the same repetitious job for 30 years, and at 30 years and 1 month, their wrist starts hurting. They go, it must be the job. And it's not, they've been doing the job for 30 years. They're 30 years older now, and the way they heal things is different from year to year. Trauma, obviously trauma can be an acute cause. You can hit something and it can start an inflammatory process. There are medical conditions that predispose people. A lot of them are the connective tissue diseases like rheumatoid arthritis, gout, and things like that by themselves can just start attacking the tissues and cause them to be inflamed and have pain. So if you look here, I don't know how well it's showing up for you, but there are an awful lot of structures in a very small space, and this is just the radial side of the hand and the thumb right there. So when I was in medical school, initially I loved ENT, and then I loved ophthalmology. And I remember that the head of the ophthalmology department always would say, the eye is the most important square inch in the body. And I couldn't really argue that now with a hand because it's more than a square inch. But I can tell him that you can read with your hand, but you can't shuffle cards with your eye. So I think the hand's more important, all right? So in general, we're kind of looking at the three main structures that are going to be running through the area that can be sources of pain on that side of the hand. Tendons, the joints, and the sensory nerves. And they're all, again, I'm not sure how well these colors are showing up. The little yellow areas here are the little sensory nerves on the side of the wrist. Those white areas are the tendons. The red is just the muscle, which ultimately turns into a tendon before it acts on a joint. And then the joints are underneath all of these structures. They're the deepest things there. So starting with the tendons, trigger fingers, trigger thumb. I'm talking about thumb because we're on the radial side of the hand today, but the pathology is fairly similar. And what that is, well, actually, let me just go through. The first dorsal compartment, which is the radial wrist tendons, and that's these tendons right down here that run down the back of the thumb across the wrist. And then this flexor carpi radialis down there is another volar tendon, and it's not nearly as common of a source, but if you look at it, you can see it just on the edge of the film right there around the front of the wrist. So the tendons I'm going to talk about first. So the trigger fingers or the trigger thumb, It's a mechanical impingement, and at its worst phase, you'll actually see a popping or a catching or a locking of the thumb or the fingers when it happens. There's a sheath that the tendons go into, and parts of it are flimsy, parts of it are very rigid, like a collar on a pipe. And so when that tendon gets inflamed, it takes up more space and it starts rubbing. Well, the flexible parts give, but the rigid parts get rubbed on and they thicken up. And eventually you get enough of an imbalance there that the size of the tendon can't get through the thickened, swollen part of the pulley, and it pops and it catches. Now, you see it out at the joint in the thumb, but it's actually happening down here where the flexor tendon goes through that pulley. And again, the changes are inflammatory in the tendon, but that pulley, that strap that it goes under, gets thickened. It forms like a fibrocartilage, so it's actually hard. In many of these things, unfortunately, you're going to see females tend to be more common than males. I was just noticing the demographic in here, and actually I'm seeing more males than I usually do in this talk. The thumb and ring fingers tend to be the most common ones. Secondary causes that I mentioned, like rheumatoid arthritis, gout, those are a whole different thing. So it kind of throws the demographic off when you have an underlying condition that might predispose to these problems. So symptoms. Initially, it just starts with pain, soreness. Sometimes you can't even figure out where it's sore. It just feels stiff. You don't want to use it, or when you're pinching something, you get some soreness in it. You may not see swelling. We always say inflammation, and people look and say, well, it's not swollen at all. But this is happening on a microscopic level. It wouldn't be something that you necessarily even look at the tendon and say, oh, look, that tendon's swollen. But there's such a fine balance in the function of the hand. Triggering, many people, when they come in, don't have the triggering. They're coming in because the hand has just been sore for a long time. They didn't have an injury, but it's weak. It doesn't seem to be working well. And I examine them, and you find the tender area in that tendon. It's not popping yet, but it's kind of on the way there. So causes, again, I put life at the top. We doctors like to blame everything else but ourselves, So trauma, minor trauma can get tendons angry. Activity, again, I don't like to say activity necessarily causes it. Certainly a sudden change can predispose you to a flare-up. But many times what happens is something flares it up. You could be sleeping on it funny one night, and then 2 weeks later you start noticing it a little bit sore. And then the things you do tend to perpetuate that. So how do we treat these? And you're going to see this is kind of a common theme through all of these problems, in which inflammation is, at least in the early phase, the biggest part of the discomfort and pain you have. So the things that you would normally do for a sore muscle, a sore tendon, modify your activities, which most of you are going to do spontaneously. You're going to say, that hurts, I'm going to do this a different way. Modalities, which are like ice and heat or paraffin baths, things that you might have access to. Splinting is a way to immobilize it. And we like that to protect it while you're doing things, but we don't like people wearing them all the time, because then everything gets stiff and it gets harder to get things moving. The non-steroidal anti-inflammatory agents are, even if you take them and you don't notice a difference, they are making a difference. The problem is many people have conditions they can't take them, or you're on blood thinners and your doctor says don't take those, or you get stomach upset from those. But those three things are a wonderful place to start. Some people want to grab a ball and squeeze it and work it out, and when a tendon's angry, that's not a good idea, but you do want several times a day to be out of your splints and fully mobilizing those tendons and those joints so they don't get stiff on you. When people come in to see me, these last two are kind of the treatment options where I kind of kick in here, but when they come in to see me for these problems, we're looking at other things they haven't tried. Some of those things at the top they haven't tried, and we'll talk about that first, but when the trigger fingers, when it actually gets to the point where it's popping and catching, it's very hard for these things up here to get it back under control quickly. When I was in training, we'd see everybody first, and we'd be ice and anti-inflammatories, and if they tried that, we'd give them a different anti-inflammatory, and then we'd say, come back in a month. And we'd see them in a month, and 10% would be better, and the other 90% would be angry that they waited a month. And then we'd go into this injection, which is putting a steroid into the tendon sheath. Steroids are analogs of hormones we all have in our body now. They have very good anti-inflammatory properties, much stronger than the non-steroidal anti-inflammatories. They have more side effects, but when we're injecting them into a small area like this, they're basically just acting like a bath on that tendon, and they can do wonderful things to decrease the inflammation here. You see, 70 to 90% when I give an injection, I'm pretty sure within 3 to 4 weeks that triggering is going to be gone. They're going to be happy with it. What we can't stop is the inflammatory process. So if the body's inflammatory process, which is what it's doing to help make that tendon or that joint better, If it doesn't get under control while that steroid's working, then when the steroid wears off or when you do something else down the road, that inflammation comes back. Now, unfortunately, in tendons, small tendons of the hands, it's not something we want to repeatedly do steroid injections into. So there are some hand surgeons that won't even talk about doing one. Most will limit it to no more than 2. Some will stretch it up to 3. But after that, you know, the risk of degeneration of the tendon and the fact that it's probably not going to make it go away by that time, we move down to the last option, which is surgery. Surgery is really not a big deal for these. I mean, I know it's easy for us surgeons to say that, but well, that's a slide I didn't have in my file, so that's actually good. This shows you, in the thumb, this is where we make the incision down here, okay? And what we're doing is we're opening up the skin, and it's hard to see, but there's a white band right across the very base of that tendon right there. That's the little tendon you see running along the thumb. And what we're doing is we're just releasing that strap. It's opening up like a drawbridge over the strap. And what we do when we do that is loop the tendon over a hemostat and just draw it out of the wound. We make sure that it's not being trapped by any parts of that strap that may not have been released or stuck down by adhesions, because sometimes that strap is gone, but it's the tendon still inflamed and stuck down. So we pull that out to make sure it moves, and then the patient wakes up a little bit and we have them move the thumb or move the fingers to make sure that the triggering is resolved. And then from a recovery standpoint, you're just closing up the skin and treating it like you would any skin cut. So yes, we're going deeper than that as far as the surgery goes, but the recovery time is just protecting the wound, not getting it dirty, not doing anything that would pull the wound apart until it's healed adequately. That strap we release is called the A1 pulley. It's even though I described it as a collar, we call them pulleys in the system. The open, which is the one I show, is the safest. There are other ways that we've kind of done through the years, kind of a blind stab through an incision or numbing it up and just taking a needle and kind of swiping it back and forth to scrape through it until it breaks. But, you know, in doing that, I've seen a lot of degeneration. You know, the needle tip gets through the pulley, but it also scrapes up the tendon and leads to more inflammation and scarring. So it's such a small incision. It's such a fast, easy procedure. Really, most people are just doing it through a small, open incision. And once we're done with the trigger release, it's less than 15% chance that it's going to recur at that level. And by that level, I mean ligaments can snap, arthritic joints can snap. There are other pulleys out the sheath that technically could snap, but really it's very uncommon for them to happen at that level. Once this is done, usually the triggering is not going to come back. But remember, the surgery does not get rid of the inflammation. The surgery only opens up the tendon sheath so that it's not rubbing all the time. So I'll get many calls at 3 months, you know, why is my thumb still sore? Why does it still feel stiff? The tendon's not catching on the pulley, but it's still inflamed. So until your body quiets that inflammatory process down, you can feel those symptoms. So moving down to the next one, this is the radial side of the wrist. Again, from the angle I don't see it as well, but this is a line kind of drawing the course of these tendons coming down the radial side of the wrist. And if you look, you can see a little swelling there. Many times we do, many times we don't see the swelling. The Quervains is what we call the inflammation of the tendons in the first dorsal compartment on the side of the wrist that go up the thumb, and they come down here. In this area of the wrist, there's 6 compartments that your tendons are divided into. And it is amazingly made. Those pulleys all act like mechanical advantages to let you get the most out of the muscle pulls there. But some of those compartments, this one's kind of the biggest culprit, there's not a lot of room in there, and there's several tendon slips that go through there. So if you don't have a lot of room and you have one tendon and it swells a little bit, it's not a big deal. If you don't have a lot of room and you have 4 tendons and they're all swelling at the same time, all of a sudden, again, you get the pain, the burning, the symptoms that you get along there, and now there's not enough room in that canal for the tendons to glide freely without rubbing. It used to be kind of middle-aged women, more common than men. A lot in the peripartum period I see now. I mean, someone has a baby and they're lifting it up under the arms, which you can see is just tweaking those tendons right there, but you're carrying a car seat, and all it takes is, it's like the straw that broke the camel's back. It's one little thing that gets that process going. And then with every little thing you do each day, it's very hard for your body to quiet it down. Also, people that pinch, twist, rotate, like club sports, baseball, and golf, a lot of snapping of those tendons around the wrist can get them inflamed. And I say everyone else down there because the vast majority of people that come in don't remember doing anything to the wrist. They're like, it just started getting sore. Maybe a few months before that I did this and that could have caused it, but it didn't hurt after that. So I think most of the time it just happens for no good reason. Something you do, you don't realize, and it just starts to catch up to you. So again, pain, and the crepitus means crunching and grinding. And I don't know how many of you, some of you had trigger fingers, and so you see the popping. You can actually get almost a sandpaper or gravelly feel as those tendons move across the wrist, like it's just grating through there. Many people that have had rotator cuff tendonitis, notice that. They come in and they think there's something wrong with the bone because it's crunching, and it's actually just the inflammation of the tendons doing that. Well, weakness. Yes, you get a little resistance of those tendons gliding through there because they're swollen, but most of the weakness is because it hurts. You're getting a feedback signal to your brain that's just telling you not to do that. It won't let you do things that it knows are going to bother you. It doesn't want you to drop that glass, so you just don't feel like you can handle those things. The burning pain is common with tendonitis, but it's also common with nerve irritation. And those little yellow structures I showed you right here are running right over the top of those tendons. This is that first dorsal compartment right here, and it's running right over the top of that. So sometimes that inflammation will irritate those nerves, and it will give you a burning pain. There's another condition of this nerve that I'll talk about in a little bit. It's not as common, where it alone is trapped and the tendons aren't the big problem, but much more common with pain in this area of the wrist for it to be this tendonitis. So there's the infant and toddler care, the pinching and the twisting. The wristwatch and the clothing. Sometimes, tight collars on the shirts, which you don't see so much anymore. But a wristwatch, even once it gets inflamed, just that little thing banging on that wrist all day can really bother you. So just getting that watch off can make a big difference. The differential diagnosis, because there are other things in the area, intersection syndrome is just the syndrome described where the first two compartments come together. So that was the first dorsal compartment. There's another one with strong wrist extensors that runs up the back of your hand here, and they cross over right here. So when that second dorsal compartment gets inflamed, you can get kind of a combined pain in both of those areas. Thumb and wrist arthritis, they're down deep to that, but they're going to hurt in the same area. So that could be coming from underlying arthritis. The flexor carpi radialis is that big, strong wrist flexor tendon I showed you at the beginning there. And then the sensory nerve entrapment that I mentioned a minute ago. So treatment, again, a common thing for all of these. Activity modification. You'll do this just out of natural selection. You'll try to avoid those activities that bother you. The modalities, the ice, the heat, the anti-inflammatories and splints. If it comes down to injections and therapy, and actually in Quervains, many times you will be able to get it under control better before coming to see us. But when you come to see us, most of the people are ready to try an injection. Therapy used to be the mainstay of treatment, and I still love it, and hand therapists are still great for all problems with your hands. The problem now is with the high deductible plans, nobody wants to pay the money and take the time to go there 2 or 3 times a week for a month. It becomes very expensive. So most people, it used to be they'd want to try the injections first and then try the therapy. Now pretty much people will try the injections, and if it doesn't go away or if it comes back, we move down to the next step, which is surgery. So this is just a schematic of the surgery right here. This is showing you that strap, this thing going back and forth here, right over the top of these tendons, all right? And so these get inflamed, and this pressure on them is one of the perpetuating factors. Again, the inflammation is your body trying to heal it. We can't change that. We can just modify the anatomy so you don't have that constant stress on those tendons. And so what we're doing is opening this up. Now, realistically, we're doing this. Where did I go there? There we go. Realistically, we're actually making this cut way toward the back of the strap. And that's because we don't want these tendons snapping and hopping over that strap as you move your wrist afterwards. So we make this a big shelf. It acts like a big hammock under the tendons. And then we tend to protect you with a splint for a couple of weeks afterwards, just to let that scar down under the skin so that you don't have as much of a risk of those tendons snapping and being a problem. This one tends to go on for longer. The triggers will feel a little stiff, but this one, even when it's released, will tend to feel sore for longer. Again, not because the tendons are rubbing, but because that inflammatory process takes a while to quiet down. And if you're a young mom carrying babies in car seats, remember, you're still tweaking those tendons. Even though they're not rubbing in that strap, you're still stressing those. Okay, and this is that other tendon I was talking about, the flexor carpi radialis. It kind of comes down the wrist, right underneath the thumb right there. It's a very, very powerful tendon. Females greater than males, but males start to get closer on this. The tunnel in this one is not mostly just a strap. It's actually 90% of a bone tunnel. And then there's just a little area on top with a ligament. That tunnel is formed actually across a joint as well. So sometimes arthritis in that joint forms little spurs in that tunnel, which can actually erode and ultimately rupture that tendon. So we still kind of look at this the same way as the other tendonitis. And the ruptures, as bad as it sounds, you can actually get by without this tendon. And there are procedures in hand surgery that we do where we actually harvest this tendon to use it for other things. We don't like to just cut tendons, but it's one of those things that if worse came to worse, you could get by without. And we've seen people in the past that come in and the tendon's ruptured, their pain gets better. So the differential diagnosis for this, again, arthritis in the underlying joints in the thumb and the wrist, the de Quervains that we talked about, a trigger thumb, because the flexor tendon of your thumb, after it comes down the thumb, it crosses in the palm and then it runs down this same side of the wrist right there. So a trigger thumb can give you pain that radiates up your forearm and wrist as well. The ganglion I just mentioned there because the second most common place for a ganglion cyst is on that side of the wrist. It's just an outpouching of the normal joint capsule that kind of fills up with this jelly-like fluid. A lot of people will come in with pain, but it's usually not the cyst that's painful. It's its effect on the tendons and the things around it that bother people. So again, many times we'll take the cyst out and they'll say, well, why does it still hurt? It's because those tendons are still inflamed and bothering, and we hope that over time that quiets down. So here's again, you're seeing this common underlying thing, modifying your activities, the ice, the heat, the splints, and the anti-inflammatories. Therapy for this one, it's hard for people to not use that tendon, so that one doesn't tend to help as much. Sometimes ultrasound will help that. The steroid injection, we almost like to do the steroid injection on this one before we do a surgery, just to make sure that that's a good source of where the pain's coming from. Sometimes if you do a steroid injection there and it doesn't help at all, you start thinking, well, maybe it's coming from the arthritis in the thumb underneath it. And then surgery, again, if it comes down to surgery for this, it's a very minor procedure where you're just releasing a strap in the wrist. So releases. Now that I've talked about how minor and benign all these surgeries are, what are the risks of doing it? Well, we'd all like to make things better without doing surgery, and hand surgeons included. I mean, we tend to not want to violate the way things are made because it's just, I mean, our hands and wrists are the perfect example of being fearfully and wonderfully made. It is a delicate balance, and so it's only when nothing else is helping and you say, boy, I can't live with this. I don't want to live with this any longer. It's time to move on. So you're making a skin cut. You're going to have soreness from that, and you can still have the soreness and stiffness from the inflammation afterwards. You could do an incomplete release. Most hand surgeons in these things are not going to get out of there until we've lifted things up and made sure they're completely released. Nerve and tendon injury, very, very uncommon. But technically, anytime you make a skin cut, small sensory nerves that run through that skin are going to be cut. So sometimes, you'll wonder why friends have a very sensitive incision after their carpal tunnel and you don't. Just little skin nerves in there can bother people for a long time. And then other sources of pain. There are many things that hurt in the hand that there is no surgery for. Like the other 4 dorsal compartments, they get inflamed, but they never really get tight. So surgery really isn't going to help that. You just have to ride out the inflammation until it quiets down. Now I'm just going to talk briefly about this. This is that little sensory nerve that I talked about in the distal forearm crossing over those tendons. This is uncommon. Sometimes it'll start when you get a hit in the distal side of the forearm there where the nerve comes out between a couple of tendons. And that can give you that burning sore pain down along the radial wrist. And sometimes I'll do that check for the tendonitis and people will say, well, that really doesn't bother me too much. Well, then we go start looking at the nerve. It's a much less common problem, but they'll get the same type of pain and burning and numbness up there. But sometimes sensitivity in the mid to distal forearm and not down where that compartment is at the wrist. The nerve itself comes out in a chiasm between a couple of muscle and tendon units up here. And there's usually a little fibrous band that crosses over the top. So sometimes it just gets pinched and it starts this irritation process in the nerve right there, which can radiate symptoms all the way out into the hand. Wrist watches, again, can be bothersome. Handcuffs are actually, it's one of the most common places I see this in. Someone was belligerent and put in handcuffs and they're fighting or they're being tugged along and that handcuff is beating on that nerve. And so, again, we try to give things a chance to quiet down first. Also, rotating the wrist and ulnarly deviating it, putting a stretch on that nerve, much like those other tendons, those can be factors that at least tend to perpetuate it. Differential on this, same things we've talked about. The tendons on the side of the nerve, of the wrist, other nerves in the arm. The nerves that come out of your neck mix and match up in your brachial plexus in the shoulder, and they head down the arm in different distributions. There's a fairly common pattern in everybody, but some people fall out of that distribution, and sometimes one of those nerves called the lateral antebrachial cutaneous nerve covers that area of the thumb and wrist. So people will get numbness and burning out the thumb and this side of the hand that's not coming from that nerve, but coming from pinching of that nerve up in the arm. And also up at the neck. A lot of people say, well, I don't have any neck pain, but a nerve can be pinched in the neck that only carries signals from the hand and the wrist and tell your brain, my pain is coming from the hand, when it's actually coming because a nerve root's being irritated up in your neck. So again, here's that same common pattern: activity modification, modalities, steroids with the nerve. We get a little more apprehensive about putting injections around a nerve when it's the only thing in the area, because all it takes is one little needle poke in a nerve and you could be in for a lot of pain and burning. Sometimes we used to inject carpal tunnels a lot, and now that we realize that as time goes on, the damage to the nerve can progress, we don't tend to try to just cover it up. We tend to just release it if it's not getting better with splints. But with this one, if we go to steroids, we're often trying an oral steroid, which does give you more side effects around the body. Probably not a good option for people with diabetes. Surgery on this one, though, is very rare, and it is usually not a source of those symptoms that you're having down there. Okay, so this is the big one. This might be the one that most people are here for today. This is the one that started bothering me a couple months ago. This is arthritis at the basal joint of the thumb, and it kind of encompasses this whole area, from the thumb and the palm down around the wrist and the back. The thumb is the workhorse of the hand, so there's a lot of stresses on it, and it tends to wear that joint down. The STT joint is one joint proximal to that on the other side of a little bone, and it can get arthritic too. It isn't as common to see arthritis in this STT joint isolated. Commonly, this is the big one you're going to see, and sometimes people have both of them involved. You can also have arthritis down inside the wrist. There are a lot of people when they're younger have athletic injuries that just seem like a sprain. They live with it for 20 or 30 years and it starts to hurt. And when I'm examining for this, I examine the wrist and there's a crunch or a pop in the wrist. Then I get an x-ray and it's like, lo and behold, they have an old tear or an old fracture that wasn't treated and now it's getting arthritic. So the anatomy of the thumb, the bone that sits under the base of the thumb here, called the trapezium, is shaped like a saddle, and it's wonderfully made. It gives the thumb so many degrees of freedom in its motion to allow it to move side to side and in a circle. The stability for that, because the bone does not impart stability, is all the ligaments around it. And loads and shear forces are significant in the thumb. Even the long muscles that go out to the thumb provide a lot of force, but these muscles down here in the thenar eminence impart a great amount of power to that. So everything you pinch out at the tip of your thumb is magnified about 4 to 5 times down at that joint. So what happens? Well, first it's going to be inflammation. And with that swelling in the joint over time, you're going to see some stretching out of those ligaments and it gets looser, and so it starts to slide around more. And then what happens from there is you get more cartilage wear, like a tire wearing down. And the wear tends to be more volar than dorsal, but to me that really doesn't mean anything. The bottom line is you're getting degenerative arthritis in there and it's causing pain. Eventually that joint starts to sublux, and we'll see that on x-rays as your arthritis gets more advanced. We see not only spurs, which are the result of the arthritis, they're not the arthritis itself. And we'll see that the thumb starts to slide out of joint a little bit. We know that's because the ligaments are stretching out and the cartilage is wearing down. They stage them radiographically. One, an x-ray can look normal, or sometimes just a little widening of the joint because you've got all this inflammatory fluid in the joint. But otherwise, the joint space looks great. And then as you get to stage 2, you'll see a little bit of narrowing. Sometimes you'll see some spurs there as well. A lot of people we see come in and they'll say, I have the spur. The spur is the source of the problem. And that's very rarely the case. The spur is the result of the problem. So people will say, well, why can't you just go in and take out that spur? Taking out the spur is just taking out the result of your arthritis. It's not going to change the rubbing and the grinding that you're doing in that joint. Stage 3 is when you get significant narrowing down to bone rubbing on bone and spurs there. And then stage 4 is when that other joint underneath it, the STT joint, becomes involved. Is there something there? There we go. Oh, okay. So this is the joint I'm talking about right down here. This is the trapezium bone. This is the base of the thumb. And this is the joint that more commonly wears down. That's the STT joint beneath it. And on here you can see a really advanced arthritis. That's down to bone on bone. And this STT is getting a little arthritic, but you can still see some joint space down there. So this is the kind of arthritis we're talking about here. And then here you can see how that thumb is starting to slide off the back of the bone. That's the subluxation I was talking about. And you're right down to bone-on-bone contact here, but look at that STT joint. Still looks pretty good right there. Up here, that's a little out of focus. This shows arthritis here, but a little sparing of that, and now this is where the STT joint is down to bone-on-bone rubbing. But in this patient, they're still going to have a lot of their symptoms from the basilar joint, even though some of them are probably also coming from this STT joint there. So what are our treatment options? Look at this. Here we go. Activity modification again. Splints are actually helpful for this. And these are the splints that actually include your thumb. It doesn't have to go way up the wrist, but something that just supports the thumb a little bit at the basilar joint. The modalities, the non-steroidal anti-inflammatories. I'll get to the injections in a little bit, but we talked about the extra load that's imparted to that joint when you're pinching at the tip of the thumb. Building up your grips on your tools, your golf clubs, your gardening implements, your cooking utensils, anything that widens that grip stabilizes that joint a little bit better and puts a little less force on it. But also moving your pinch and your grip down into the thumb or avoiding the thumb altogether. You know, I don't have a pen here, but a lot of people will just transfer their writing over like this. They just avoid the thumb and you're saving it. You know, you're basically not driving your car on those worn out tires as much. You're trying to put less stress on that joint to give the body its best chance to quiet down the inflammatory response. Now, some of the pain is coming from bone-on-bone contact. Some of it is coming from the inflammation that's a result of that contact. How do you know how much from either? Well, most of the time, even those people that I showed you, those bone-on-bone contacts, if they're coming into me for the first time, in other words, you know, it's hurt me before, but now it's not getting better, a lot of that pain, even though they're down to rubbing bone-on-bone, is inflammatory. And we can do an injection into that joint, and it will make them feel great. I mean, and the injection's only around for about 3 months, but many times after that shot's gone, months and months and months after that, they're doing great until they do something to tweak the thumb and get it flared up again. So unlike the tendons where the repeated injections are not a good idea, many of us that are hand surgeons say, well, it's already a bad joint, and at the end of the road, we're taking it out anyway, so who cares if we put more steroids into that bone as long as it's not causing you any skin problems or other problems. So I have people that for years, they're getting injections and buying time before they do a surgery. Now, you hear so much about joint replacements and how far we've come, but even my partners that do total joints, they really want to keep God's equipment intact for as long as we can. We can do replacements, and when it gets bad enough, you'll be happy that you had the surgery. But if you can make what you've got good enough without a surgery, that's always the way to go. So we're not treating the x-ray, we're treating your symptoms and whether or not we can bring them under control without surgery. So surgery is kind of the last step on joint replacements. In the very earliest phase, for years, if the joint looked good and it was just laxity, we'd go in and we'd try to tighten up the joint, and we figured that the laxity was causing the pain. Many people now feel that that helps the symptoms only because you're making the joint so darn stiff that it's not moving around much anymore. It's still an option. We tend to reserve that for people that just, you know, you look at it and you say, gosh, you're really young to be doing a thumb arthritis surgery on right now. So we do things like the ligament reconstruction. Some people talk about arthroscopy. It's a fun little thing to do, but it probably doesn't buy you a whole lot of time. It's probably more for you to go through than what you get out of it. And they've found, same thing with knee arthroscopies, they'll probably find it in the next 5 years with hip arthroscopies, that if it's arthritis, cleaning it out can make you feel good for a little bit, but it's usually not real long lasting. But they can buy you some time before you have to move on to bigger things. So the definitive basilar surgery, the one that is most commonly done, is this top one, this resection of this bone, and using some of your own tendons that we roll up in there as a spacer, And many of us do a little tendon transfer to create a little hammock under that thumb to help keep it from settling. For years, we were pinning these. And then a lot of people said, well, the ligaments help hold it in place, let's not pin them. And so I went to not pinning them for a long time. And I did see more settling of the thumb down into that space. So I've kind of gone back to putting pins in there to stabilize them for about a month and a half. Because what we want that space to do is fill in with a good wad of scar tissue. Resurfacing, people have experimented with that. There was an implant called Artelon it's still there, and it was used. It was pretty popular when it first came out because we all wanted to preserve pinch strength and keep this bone in the hand without having to take it out. So what we were doing is just shaving off the top part of that bone and putting a little piece of carpet square on there essentially, so that you weren't rubbing on the bone, you were rubbing on that piece of carpet. Many of my patients did really well with that, but some people they found just got this chronic ongoing inflammatory response. So the favor for doing that kind of just has departed for the most part now. The implants, we've gone through things. One was a little sphere you put in there. We've gone through different two-piece implants. None of them have really held up. You'd think that a big joint like a knee and a hip would put a lot more stress on a joint replacement, but it's not true. The angular loads and the more degrees of freedom of motion at this thumb make it very hard to get an implant that you can really stabilize long term. What happens is that toggle causes it to loosen. Instead of having those big long stems like you have in the hip and the knee, you've got these tiny little buttons because they have to fit inside these small bones right there. And so they haven't really done well in the long term. There is one that's come out in the last couple of years that many of us are keeping our eye on as far as an implant. Metal and plastic ultimately is going to fail. It's not meant to be in there, and if you're alive long enough or you tweak it enough, it's meant to fail. But keeping something solid and hard in there can preserve pinch strength a little bit better. So sometimes people are looking at it like, well, this might be a good time buyer for a very young person that you don't want to take that bone out of real early. And so you buy time by putting something in, knowing that down the road, if I put an implant in here, I can ultimately take it out and take this bone out and do the same reconstruction that we just talked about. So arthrodesis is the fusion of that joint. It's, again, a lot of times in very young people like carpenters will do that to preserve strength. The problem with that, the good things is it gives you a stable pinch and column, so it doesn't take power away as much. You do sacrifice motion of the thumb with that. And the problem is, just like fusing vertebral levels in your spine, when you fuse one level, you're putting more stress on the other levels that are still moving. So it's going to tend to accelerate wear in that STT joint, which means, again, down the road, you're going to have to come down, take out the fusion, take out the bone, and do that reconstruction. So again, more people now are just buying you as much time as they can, and then they're going to that trapezial resection interposition arthroplasty. And so here's that joint with the subluxation, the arthritis there, and this one's pretty well spared, so you don't have to do anything with the other side of this joint right here. I don't know if that one's good. Yeah, there it is. Okay, so now that's the trapezoid. That's not the trapezium. The trapezium has been taken out over here, and these are pins that are holding that space open. Now, you can't see them, but there's tendons rolled up in there, and there's a tendon transfer that's woven like a hammock underneath this to preserve that space. We want to have that cushion there. Boom. You take the pins out, and now you've got a good wad of scar tissue. It's a nice soft pillow sitting in there under the thumb. So now when you pinch, yes, the thumb can piston a little bit and not have as much power, but you're not rubbing two bad bones together. So the pain is a lot better. Is all the pain gone? And the answer is not necessarily. One, you've gone through a big surgery where we've taken a bone out of your thumb and there's scarring and there's muscle there that's sore. But the other structures over that can be contributing some to the pain too, and that's the little sensory nerves. You can have tendon and muscle soreness that aren't even related to the arthritis. And those things surgery can't help. That's it. Those are the things on the radial side of the wrist and the thumb. And those are, if you're having problems there, those will probably include about 95% of what you're having.